Next on call, headaches,
in my mind, it's really three different patients.
over-the-counter medications, and pain management.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
There's the valve.
And which was healthier, the yogurt and the bagel?
All right, I'm going to start by measuring the size of it.
You could also add grilled chicken to this recipe.
Whoa, hard. Whoa, whoa, whoa. Keep pushing.
Just your head.
Pull red handle to open bag.
Hello and welcome to On Call. I'm Tammy Watson. The concept of pain is a pretty broad topic, and when we throw headaches into the mix, we've got a lot to talk about, and that's exactly what we're going to do here tonight. We'll find out how doctors diagnose pain and what the treatment options are for different types of pain, including back pain, migraine headaches, cluster headaches, the list goes on. Here with me in the studio tonight are Dr. Annette Bosworth, Dr. Judith Peterson, and the On-Call medical editor, Dr. Rick Holm. They're ready to answer your questions about pain and headaches right now. You can call in to our toll-free number. It's 1-888-DOCTOR-ON-CALL. Again, that phone number is 1-888-376-6225 for questions about pain and headaches. Helping to answer the phones tonight and to take your questions are volunteers from the Brookings Health System. Now, later in our show, you're going to see stories explaining how pain management clinics work and how over-the-counter medications are used to treat headaches. But first, Dr. Holm, I want to know, how do you diagnose pain? Is it as simple as, on a scale of 1 to 10, how miserable are you?
Well,
not really, huh?
No. It is probably the biggest challenge that you have every day in caring for people. The first thing you think, the last thing you want people to do is suffer. So your first thought is, how can I help them with this and help them reduce suffering? But then but actually the real first question is, what caused this? Is there something that is going on that's bad? Chest pain that's a heart attack. Do we need to move on that to quickly alleviate that with a thrombolytic or a ship to the angioplaster? The second question is, or what can I do to help understand why it's happening so that I can alleviate it? But the other thing is that sometimes the person presents with back pain, and what's happening is that he's losing his job, or he's not performing at home in a sexual way that is being expected of him,
so there's
or
really
that she
is
lost her child and is in the doldrums. I mean, there is a lot that it can be. A lot of it can be heartfelt pain, and they present with a physical pain. So you, as a physician, have to listen really hard, and try to understand the whole realm of it. And oftentimes, you're just shooting in the dark because you're asking for clues and you're not getting a lot, and you have to interact as well as you can. It's the most challenging thing we do every day. And I'm pleased to introduce our guest for this evening, Dr. Annette Bosworth from Independent Medicine, and Dr. Judith Peterson from Sodak Rehab in Sioux Falls. So we're going to start with you, Annette. Now, who the heck is Annette Bosworth, and what is independent medicine? I mean, obviously you're from where?
I'm independent.
Yeah. You're originally from?
I'm from Plankington, actually, born and raised in South Dakota, a hog farmer's daughter. And I trained at USD and went to my undergrad there, did my medical school there, and then I practiced for about a decade in Salt Lake City, Utah, where I got my internal medicine residency finished, and then had lots of connection with the people who trained on psychiatry as well as who trained on pulmonary medicine. Those were several of the places that I took pleasure, and I've used those talents to see patients for 13 years now.
And you've been back to South Dakota for how long?
About 4 years.
So, and you're Sioux Falls?
Yes.
And, okay. And Judith,
yes.
You've been here a couple times before, like, what, 8 or 10 or something like that? And you're a physiatrist. What is a physiatrist?
Physiatrist is physical medicine and rehab, and physical medicine and rehab doctors do non-surgical management of neck pain, non-surgical management of a variety of types of pain problems. Also, physical medicine and rehab doctors do a lot with sports medicine. And really, the unifying theme is that we are trying to maximize patients' function. So rehab doctors are doctors of function who believe that exercise is medicine.
I'm right there with you.
Absolutely.
Right?
So.
And that, so my background is I trained at Rehab Institute of Chicago and Thomas Jefferson University Hospital, and I've been practicing in Sioux Falls as well.
All right. Well, welcome the both of you. And this is an opportunity for anyone with any pain or with friends who've had pain or questions about pain, different kinds of pain. We'll take any kind of pain. And we challenge you to ask us something that will turn those cranks around up there. So give us a call. We'll be right back after this.
Tension headaches are one of the most common forms of headaches. They may occur at any age, but are most common in adults and adolescents.
Pain management can be a complicated process. For one thing, we're all individuals, so the way we perceive pain and the ways we respond to medications intended to treat pain are variable. Pain clinics work to have a better understanding of how our bodies experience pain and focus their treatment on a variety of strategies to manage pain. On Call spoke with one of the medical directors at the Regional Rehabilitation Institute Pain Management Clinic in Rapid City to learn more about this.
Rapid City Dr. Stephen Frost is a co-medical director at the Regional Pain Management Center. He says that over time, the diagnosis of pain has become more precise.
Traditionally, we used to diagnose pain from a visual analog scale from 1 to 10, 1 being minimal pain, 10 being the worst, and that's purely subjective. We can have ranchers come in with bones sticking out saying my pain's 1 out of 10, when can I get back to work? We have patients blowing bubbles and telling me I have a pain 10 out of 10 with their legs crossed. So what we try and do now is incorporate what they do for normal activities of daily living and how it affects them emotionally.
Frost knows that managing pain involves a lot more than simply sending a patient to a pharmacy to fill a prescription for strong painkillers.
We stress education for the patients. It's a two-way road to treat chronic pain. We simply just don't want to give them medications or stick a needle in them. We want to also educate them that if we can cut your pain by half, I consider that a home run. I never guarantee patients 100% pain relief. You're set up for failure. And it's time-consuming, and that's why a lot of primary care physicians don't want to deal with it. And that's what our job is to do, is to listen to the patient, formulate a plan, and then include them in that plan, telling them that they are responsible for their pain, the diary, the follow-up, and to follow up with like physical therapy. Otherwise, we're not going to be able to help.
Over-the-counter medications like ibuprofen and acetaminophen are all part of a pain doctor's arsenal. So too are prescription medications that include narcotics. But Frost says when it comes to treating nerve pain, a new type of drug does better than narcotics.
A class of medication called anti-epileptic medications or seizure medications have been shown to help nerve pain better than narcotics. And these newer medications work different than the narcotic medication. They actually have the brain, what they think, inhibit the pain transmission. And so these new class of medications are non-addictive. Side effects don't include respiratory depression or constipation. And they truly do help nerve pain better than narcotic pain. So that advancement has truly helped my patients.
Doctors, let's talk more about the anti-seizure medications that he spoke about, and then also just the idea that narcotics are not the be-all and end-all for pain.
Well, I mean, and neither are the anti-seizure or neuroleptic medicines, but mostly they're gabapentin, which is Neurontin, and Lyrica are the primary ones that we're using right now. Any other?
There's topiramate. There's a variety of different anti-seizure drugs. The anti-epileptic drugs were originally developed to treat seizures, and what that tells us is they're going to be acting at the brain and on nerves, because of course seizures is an abnormal kind of brain signal that's causing potentially abnormal muscle movements.
So it's the neuroleptic. They work on the nerve level. Most of them take you down a notch, so a little less aware, right? Because they are anti-seizure medicines.
Well, you know, if you think about it, if you have a seizure, you have dramatically increased activity. So if you have a drug that's going to work as an anti-seizure drug, it's pretty much going to have to knock things down about a peg to be functional. But really what they do is they cause nerve transmission to not have abnormal spikes that can lead to pain.
Can you abuse these or
They're not usually abused, are they?
They're not really the type of...
They're not typically thought of as drugs of quote-unquote abuse, but they have side effects, because if it's going to be a powerful drug that's going to work, unfortunately, you have the potential for side effects. And, you know, these drugs, it's not just the fatigue. They can affect sodium levels for patients. So they can cause...
Hyponatremia, for example.
Right, so they can be problematic.
The older people can fall and break hips. I mean, they cut you down a bit.
And you can get double vision.
You know, and you're just less alert.
Yeah.
So there's a price that you pay. But they work. They work in some people.
Well. The other thing that I always think about when I'm picking a medication is that I like to know what it does to their sleep. I mean, pain gets reset when you get into that deep sleep. And so when you have medications that, like narcotics and like benzodiazepines, that are used frequently for acute problems, but then they get carried into a long-term process, it really disturbs the natural way our brains are supposed to fall asleep. Neurontin does improve that sleep cycle, and so even though it has a fatigue side effect, I think that plays into, that's why it's a better drug long-term for many of these pains.
It allows a person to fall asleep, and that's part of our healing process for pain. I know that when a person presents with a migraine headache, one of my most effective treatments, and I go oral, not shots, is just to put them to sleep with a knockout drop. I give them hydroxyzine, I give them Lortabs, and I give them Valium. I mean, or not Valium, but a benzo. So they fall asleep, and then if they wake up, I give them, they have another extra oral packet to take, and they sleep it off. And I mean, that's how you get rid of migraines for the most part.
Well, if you think about it, you have, you know, certain pain syndromes like fibromyalgia, and one of the principal issues is that people have non-restorative sleep. They sleep, they wake up, they still feel like they've been hit by a truck. You know, so non-restorative sleep.
So do you use the gabapentin, Neurontin, or the Lyrica type of thing for that same problem, for the
Well, absolutely, you could use Lyrica for fibromyalgic pain, because fibromyalgic pain is now thought to be not a problem with the muscles. It's considered to be a problem of how the brain processes pain signals. So if you think about that, we're back to that whole brain thing again. So, you know, the Lyrica, pregabalin type medications make sense.
But that's kind of spendy. The Lyrica is like how much a month?
About 100 if you're paying cash, 150 maybe.
150.
They're of the same class, the gabapentin and the pregabalin drugs.
Yep. We have a question that falls right into this conversation. A caller from Huron, age 70. How do you know if you have fibromyalgia, and what pain medicine do you prescribe, or is there another way of treating it? So can you explain what fibromyalgia
Right. Before we go back to medicines like narcotics, because we should spend some time on narcotics and non-steroidals and when we're on medicines, but you know what, fibromyalgia is a great topic.
Absolutely.
What the heck is fibromyalgia?
So I'll take this one actually. You know, I think of myself as a brain geek, like studying what the brain does during pain syndromes and how we respond to it, how we repair from it. And I think when I'm asked that question about what is fibromyalgia, one of the most powerful things I do before I answer that question is take their history about where did this come from, how long have you been suffering. And I am continually impressed with how many of the patients a decade ago suffered a trauma, usually a mental trauma, that stopped their life from being normal. Whether they lost a child, they lost a spouse, they have a surgery that they never really recover from, and they stop sleeping correctly. And they have some pretty good PET scan data on humans. I mean, the animal stuff was pretty interesting, but on humans that say the longer...
PET scans are brain scans.
Correct, yeah, thank you.
PET brain scan.
Yeah, it allows us to, I always say, we can watch you think. And then I correct to say it's not what you think, just where you're thinking. So they get a little paranoid, like, I'm leaving if you know what I'm thinking. Yeah. But when you look at the way brains think and the way the brains process pain, it becomes less and less predictable the longer they've gone with this without normal sleep. And so you look at the personality that's usually there with the fibromyalgia. And I actually think the poor rheumatologist really got the short end of the stick. When we thought it was joints and muscles, they had all the consults in the country to say, well, something's wrong with our joints and muscles, and they're left to handle it. When all along it has continually pointed back to say,
something in the brain.
They are misfiring. One explanation that I really liked was there is like a short circuit within their brain, and it's not exactly true, but when you look at how their brain just can't shut down, it cannot reset. And that usually started when something traumatic happened, divorce, whatever, and they never really got back to a healthy sleep cycle.
So, and do you diagnose it with the pinches to say that they hurt in all these different places, or do you really by the pattern of the discomfort? And number two, do you use something for their sleep to treat them?
Yeah. Yes.
And the answer is?
So I diagnose them with the history is usually long. They've usually got a psychological problem that has accompanied this. They've had something major change their life. And then they haven't been sleeping well. Sleep is very highly correlated to whether or not the fibromyalgia ever got to a healthy or to a level that you can see. One of the other ways I explain to patients is that they did a study of thumb pinches. So they set the hydraulics of a thumb pinch to say, here's what it does to normal brains. And they put people under the PET scan and they watched their brain feel the pain. And then they did it to a fibromyalgia patient, and it's like a little seizure was going on. All this chaotic electricity, not electricity, but signal was coming from the PET scan. And you could see that get better and better and better the longer their sleep pattern had improved. There's other things that I think are really important, that if you're going to repair these parts of the brain, their neurotransmitters do need to be higher than they are at the moment.
So the SSRIs?
Prozac, some norepinephrine reuptake inhibitors, I think, are also a very good way to augment the pain.
So what sleeping medicine?
Okay.
Mirtazapine?
That's a good one. Yes. Pushing stage 4 sleep, the best one out there still, I think, is... Yes, no, it doesn't. That'll hold it in stage 4 sleep, but if you haven't been to stage 4 sleep, still the one that wins is olanzapine. Expensive, $10 a pill.
What's the brand
That's
name?
Zyprexa. And so it will...
So it's a major tranquilizer.
Yeah.
But it's not the benzos. You really don't want the benzos.
Not. Benzos, actually, if you're blinded and you're studying a sleep study and you don't get told who's on alcohol and who's on benzos, when watching their sleep, you can't tell the difference.
So
it impairs problem-solving ability. Which in the elderly, which in the elderly can be problematic. But for your guy, one thing who asked the question, widespread aching pain, non-restorative sleep.
So just feeling achy, like
achy, generally achy. But one thing I would say is people think that, I have fibromyalgia. That's it. I have fibromyalgia. But you need to get checked to make sure that you don't have, particularly in this age group, certain inflammatory muscle conditions that need to be treated with a steroid that could be potentially dangerous to your health.
Polymyositis, polymyalgia rheumatica.
Okay, so this person needs to go talk to his doctor, because the polymyalgia rheumatica and other conditions can be treated. And you can always have, things being what they are, you're always, unfortunately, can have more than one problem. And fibromyalgia, actually, people say, oh, you have fibromyalgia, you have fibromyalgia. But of course, you can have rheumatoid arthritis and fibromyalgia. You can have a variety of conditions in fibromyalgia.
You can have depression and fibromyalgia. You can have ulcers and stomach problems and heart disease, and it goes on and on, particularly
but widespread aching pain, non-restorative sleep.
That's the real clue.
Are two really good clues to think about and then go talk to your primary care provider.
So that's where I start my doctoring, is
Yes.
go to my main doctor, my primary care doctor.
Make sure that you're not missing something.
Right, and that it's not a clue to some other condition that needs to be treated.
I've said this to fibromyalgia patients who, I have fibromyalgia, they say. And so, and you know, you try to help them with the pain, but oftentimes I have in the past been not successful. Perhaps I'll be better now after tonight listening to you guys. But one of the things that I always encourage them to do is to get out of the cycle of non-activity, because what happens is it's brought them down to being a complete couch to potato. And the answer is you've got to get into this restorative activity. This exercise is medicine is my treatment.
Absolutely. Well, that's a good question. When it hurts to exercise, or when should you gut it out and force yourself, and when do you need to ease off?
Well, the American College of Sports Medicine recommends moderate activity most days of the week for adults who don't have a major cardiac condition or just. But you're right, it's hard to exercise when you have pain. Does that mean you should not exercise? Not necessarily. It just means you start slow. You start slow and you gradually build up, because studies show that you can get benefit from short duration exercise, that you, instead of maybe doing a half an hour, you do 5 minutes, and that's still a lot better than nothing. And if you don't feel like walking fast, well, maybe you walk slow. And if you don't feel like you can handle walking outside, maybe you should walk in the grocery store or at the mall. So in a controlled fashion.
And let's switch a little bit to narcotics. Is there ever a time I'm going to say that narcotics would be good for fibromyalgia, yes or no?
No.
Okay, and no, and but the narcotics are important. I mean, Lortabs. I mean, hydrocodone with Tylenol or with APAP. Those are reasonable pain medicines and probably safer than nonsteroidal anti-inflammatories like ibuprofen and Aleve, right? Not necessarily.
I like using the analogy that an anti-inflammatory does really focus on taking away some inflammation, whereas a narcotic really is, it just stops the brain from perceiving what's happening in the body. And so I think when I think a problem is going to be short term, I'm pretty comfortable with using a narcotic for an injury. But if I think there's a long-term problem here, I consider it a failure on my part if I end up using a long-term narcotic for a patient before I've tried many other things.
Well, at the end of that line, I will, I feel more comfortable using a narcotic even than I do the nonsteroidals, because long-term nonsteroidals are so toxic. Judith.
There are additional medications that have been approved by the Food and Drug Administration for fibromyalgia. So, we talked about the anti-epileptic class, but, there's Cymbalta has been approved.
Which is in an antidepressant group.
Correct. And Savella has been approved.
Which is also in the antidepressant.
Correct.
So those are with the brain chemistry again.
Correct. So, people have options, but I think one thing that we underuse is activity for people with fibromyalgia, because of course deconditioning becomes a separate medical problem. And when you impair blood flow going to muscle because of deconditioning, oxygen is not going to muscle. So this, if you think about it, is not going to be good, since what's our very important muscle, our heart. So,
I had a guy come in recently. And he said, it's unbelievable how much better I felt when I started walking that mile a day you told me to do a year ago. I can't believe how much better it was. And I want you to know that it can't right through the winter. It came to summer, I started being active in the yard, mowing lawns and so on and so forth. And he says, it's helpful, but you know what? It's not as good as walking. And I went, whoo-hoo. So, there is nothing like it. A mile a day, 12 blocks. Okay. Hard to beat that.
Well, we better dive into some questions here. We got a caller from Sioux Falls, a lady age 53. She gets cluster headaches. Where do they come from? How are they treated? One doctor told her that her hypothalamus is larger than normal. Could this be the cause?
Yeah.
So,
cluster headaches, definition of cluster headaches. I put them close to trigeminal neuralgia. I see it as a neuropathy, and I see these cluster headaches are these headaches that come in clusters. They'll be severe. They'll be so severe. Some people have committed suicide with cluster headaches. They will occur. They will reoccur, and then they'll go away, and then they'll reoccur in a timer over a clustering period of time. But that's a variable deal, and it's generally one-sided. It sounds like a migraine. It really sounds like sometimes, because that's a vascular headache. But it sounds to me almost always that it is more along the lines of a neurologic.
So you think it's a nerve thing?
Almost like a trigeminal neuralgia. Any other comments? The same drugs that work for trigeminal neuralgia or help with severe migraines seem to work with cluster. Any comments?
First thing, I think it's interesting, cluster headaches are more common in males, and so it just makes you want to know, is the diagnosis right? I mean, I know that doctors are trying to take a history, and we don't get the luxury of looking inside their brain to see exactly what's happening. We're guessing based on their story.
Yeah.
And even if we did look inside their brain
we couldn't
with an MRI,
right,
it frequently reassures us there's not
I'm talking about like nanotechnology. Some little guy in there and say, what is happening?
Oh, you're back to your PET scan.
Yeah,
you're
there you
looking
go.
at people think.
No, futuristic, more futuristic.
So do women
None of those patients are walking away. Okay.
Do women get more migraines? Men get more cluster headaches? How does that break out?
Migraines is a vascular headache. It is a painful, probably an ischemic brain, because you have a vascular system that for one reason or another tightens up, closes off the blood flow, and then subsequently has a dilation response, and there's this pounding with the vascular system, and it is a one-sided vascular thing, mostly in younger women, like 20s, 30s, but it can be in men, it can be in older women.
You're talking migraines now, right?
That's right.
Yeah. So the hardest part is that migraines, they have a pattern too, and I have a tough time, I usually struggle to communicate to the patients how important it is to prevent these, and it is an exercise plan. It is the tough things that we're trying to get patients to do to prevent things.
And when you have it happening enough, there's medicines to do something to prevent, like the tricyclic antidepressants, and they prevent it. Beta blockers, calcium channel blockers, amitriptyline, things like that.
Yeah. But I think, sure, you can give them a medicine. There's always these medicines, and we have plenty of them. We have a big bag of medicines. But I think sometimes the hardest part was to motivate them to not have to like, how can you help me? And when I started to say that there is cell death with migraines, and when they started to hear that these migraines cause damages, that there's an earlier set of dementia for every migraine you have, suddenly I had their attention. They were trying to help me. They were trying to do things like massage, physical therapy, walk, do things that they took more ownership in when they saw the long-term consequences.
A bad migraine.
Yeah.
Good point.
There's so much more, but we got to go back to the videotape. Over-the-counter medications are one of the medical mainstays used to combat headaches. On-Call wanted to learn more about OTC medications and the other drugs prescribed to headache sufferers, so we met with a pharmacist to get the details.
Oh, it went okay.
William Hayes is an assistant professor with the South Dakota State University Department of Clinical Practice, and he says there are two types of treatments when it comes to headaches.
There's the acute treatment, so that would be for I'm having a headache now, I need treatment, or I'm having symptoms that I think I'm going to have a headache in the near future. It would be an acute treatment versus preventative.
Hayes explains which patients might need preventative headache treatment.
Some patients, they have such frequent headaches, or they have contraindications, meaning they can't take certain medications, or they have a predictable pattern. We find that it may be a better idea to treat them, preventatively versus, after the fact.
Hayes says that over-the-counter medications often work well for taking care of the acute or immediate pain of tension-type headaches, but preventative treatment for headaches requires something else.
For preventative, there are some options out there. There's some pretty good evidence with a class of medications called the tricyclic antidepressants. Amitriptyline has a lot of evidence for the use of preventative and tension-type headaches. And also there's some promising things with venlafaxine or Effexor. So a couple options that we see for the prevention of tension-type headaches.
Hayes says that certain types of patients might want to go ahead and consider preventative treatment.
In my mind, it's really three different patients. A patient that has a predictable pattern, so every time I work out, I get a headache. That would be, well, maybe we could look at preventative treatments. Patients that have very severe headaches where we may not have options for acute treatment. So if let's say we have a patient that can't take ibuprofen, can't take acetaminophen, can't take our prescription options, that maybe we need to treat up front. Or frequent headaches. So if we have a patient that has 3 or 4 headaches a week, that it's just not appropriate to treat acutely, 3 or 4 times a week. So that would be probably, in my mind, the other patient that we'd want to look at preventative treatments.
Cluster headaches cause repeated, intense bouts of pain, lasting from 15 minutes to 3 hours or more.
Thank you for joining us tonight. We're taking your questions about headaches and pain management, and here live in our studio are Dr. Annette Bosworth, Dr. Judith Peterson, and the on-call medical editor, Dr. Rick Holm. They're ready to answer your questions, so you can call in right now. Our phone number is 1-888-376-6225. Any quick comments before we dive into the question stack?
Migraine headache, we talked a little bit about other therapies. You were talking about...
I think that people need to think for chronic migraines that, it's true that we have oral medications, but recently approved has been Botox for the treatment of certain types of headaches.
Certain types, not all.
Okay. Not all migraines, but this might be something to pursue in a discussion with your primary care doctor, because these are medications that are injected and don't have the mental side effects of some of the other medications that could be used.
But they're very expensive.
Injected into the scalp, into the brain?
Yeah, into the scalp, into the head.
Okay.
Yeah, the skin, not into the brain.
No.
Not through the skull.
No.
Into all those muscles.
This is an in-office.
And it works.
Well, they've approved it recently. They feel that it's beneficial.
And have you had enough experience on this, do you think, yet?
It's not a technique that I personally do.
Okay, all right.
All right, we'll dive in. A caller from Watertown says, people who have had a stroke sometimes have a terrific headache first. Is there a common site where this headache occurs? In the front, in the back, on the side of the head?
It's a focal. It's not the whole head, and it's not in the back of the neck. It's here or it's over here. I mean, it's a focal.
The blood clot is.
And the worst headache I've ever had, and a person who's never had headaches, get thee to the emergency room, because you could be having a bleed of some kind, or you could be having a thrombosis. But mostly, those kinds of headaches are bleeds.
Yeah, I also think they should look at their blood pressure. That patients will come in and have a high blood pressure, and that will help us predict who's at risk for that stroke. They can't feel blood pressure, they can feel the headache, and so sometimes that's a great teaching moment to say, you don't get high blood pressure for one day and have strokes. You have high blood pressure for a year before they have a stroke. Yeah. And so,
yeah, good point.
All right. A question from Sioux Falls. Gentleman wants to know the best way to control post-herpetic neuralgia.
Wow.
No,
so explain what is post-herpetic neuralgia?
After shingles, you have a pain in the nerves that's residual, and the older you are, the higher chance of it having a after herpetic, after shingles neuralgia, pain, after shingles pain.
So hop in the time machine, get your chickenpox vaccination
That's
before
the point.
you even
Good
get it.
point, Tammy, nice point.
This doesn't work though. So
no, and sometimes the time machine, going back and getting that chickenpox, prevents it or lowers the incidence, and the data says the post-herpetic neuralgia is much less. But that being said, what about the post-herpetic neuralgia? And the answer is I have, and I know people cringe on this, I treat again with the anti-herpes drug, because I worry that acyclovir wasn't there, or that there's a recurrence. And I've seen people who've had pain go away as you treat it. So I just treat them over again with acyclovir. And then I'll treat with the neuroleptics, the gabapentin type of medicine. Any other comments?
And I think that, for this kind of pain, which is basically, it's a neuralgia, it's a nerve that's painful, it's worth talking to your doctor about getting referred for a trial of electrical treatment, which can block the pain. Basically, nerves work by electricity, so you can actually have pads that are attached that can be adjusted that can help block pain. Also, we talk a lot about the anti-epileptic drugs, but there are other drugs that are very, very helpful for burning types of pain. Lioresal, the antispasmodics, can be very helpful. So it's not just one class of drugs that can be beneficial.
I'm going to interrupt. And another
Yeah.
class is hot pepper cream. To rub pepper cream on that, and it capsation.
Yeah.
I think that's the,
And it burns, and the burning, it's hot pepper. It's basically.
But just a cautionary, the cautionary comment. Because it burns and because it's hot pepper, people who use this, particularly if they're going to use this anywhere near their eyes, have to be extremely careful not to get anything into their eye, because they will have a very severe eye irritation.
But the worst thing is to rub your eyes or rub your groin. I mean, as a guy, I've seen people have terrible burning in wrong spots. So that's a little joke, but it's not a real. It's a real deal. So you wash your hands really carefully after it's been rubbed in. Gloves. Get the gloves. Take the gloves off after you're done.
Yeah, I've had a patient with such bad post-herpetic neuralgia that they actually trimmed the nerve. They went in and she had a surgical procedure to dissociate. They cut the nerve.
Did it work?
It did work. And I was worried. I'm like, what if it controls the muscles, not just the somatic or the sensation? So that's an option. Boy, I'd wait a long time before I chose that.
Explore the other things first.
Yeah.
Okay.
But I think that's a really good point, because interventional anesthesia has things to offer for certain of these focal pain problems. One nerve is affected, for example. It can be beneficial. So not just an oral pill.
Right.
Okay. Another question: what role do antidepressants play in pain control? So I think
I will give the answer that I have. It's those medications are the most important and most powerful pain medicines we have, and I'm quick to use, the classic Prozac or Zoloft, which is fluoxetine and sertraline, for pain. And they go, I'm not depressed, and the answer is I'm using it not for depression but for pain.
Great.
Comment.
So you can actually, there's a great study that was out that says we can predict how well you're going to do with that back surgery, and the best predictor still was a screen for depression. That if they had depression and they were going in for back pain, you should time out and treat their depression before they go in for back surgery, because you played it forward 2 years, and if they had depression, if they had a score of even 5 on that depression screen, the back surgery didn't do better.
All that, the real hardcore surgery that it didn't fix anything.
Well, and you have to also remember, and I make this comment, and it's from multiple television shows with orthopedic surgeons, and the answer is surgery is for the back is not for pain. It doesn't work very well for pain. It's 80% are better after the back surgery for pain, and if you didn't do surgery, 80% are better. The reason you do the surgery is for the loss of function. And so when someone's losing function, get it fixed. That's fine. Go to the surgeon. Get cut on. Have that repaired. And it doesn't always work, but that's the indication. And the MRI of the back is indicated when you're thinking you need to do surgery. So if all you've got is pain, I generally don't do the MRI. Now, Judith,
well, I
you
have
may
a comment about the antidepressants. People. I think that it's important to remember that the antidepressants that are used for pain often are very effective in doses that would not be used to treat depression. So something different is happening.
Yeah.
And when patients have chronic pain, the neurochemicals in our brain literally get out of balance. And part of what the antidepressants do in that type of setting is they can help restore the balance of the neurochemicals that your brain needs to allow your body to cope with that pain. So it's not necessarily that you're using the antidepressants to treat a depression. The patient may be depressed or not, but the patient does have a pain problem that can have affected the brain chemical levels.
Amitriptyline, which is an old antidepressant. I use 10 milligrams of amitriptyline to prevent migraine headaches. Right. I use 10 milligrams of amitriptyline for chronic pain syndrome. 150 milligrams is a dose for depression. Right. And it's amazing, this magic medicine. Of course, it has some side effects, but it is a wonderful example of just what you're saying.
Oh, absolutely. And I think that, and you speak to something very important, which is that, if you're using a medicine and gosh, you're just going up on the dose and you're going up on the dose and you're going up on the dose, but your pain levels are not going down and down and down, maybe this is an opportunity to speak to your doctor about, is there another medication I should be adding? Is there a medication I am taking that is interfering with the effect? Am I taking my medication at the right time? Am I confused about my medication? Because you and I both know, and I think we all know,
They don't always take their medicine right.
That there are multiple opportunities for confusion in terms of how people take their medications.
Well, and one other thing is there something else happening that you're missing? I mean, is this cancer that was the bottom of the line, was the beginning of the problem that we hadn't caught yet? Maybe we need to follow through and, look at this, we missed this. You just don't always find, I don't care how good you are as a physician or as a CAT scanner or as an MRIer, you don't always find the cause.
Correct.
And so when changes are not being responded, we need to be...
Yeah, absolutely.
Which means that you need to allow your physician to monitor, which means that you need to allow your physician to do the best job your physician can do for you, which means you get to talk to your physician.
Yeah, call her or him back.
Okay.
There you go.
All right, I'm going to interrupt and go back to another question here. Female caller, age 72, and this might, we'll see if it fits into the back pain discussion. Has pain at night in the thigh down to the ankle, right leg drops when she walks with the walker, left one beginning to drag. She sleeps in a recliner, her leg jerks. She takes the yellow pill we were talking about. Is there any other treatment? I'm not sure which yellow pill she's referring to.
I don't know what the yellow pill... I'm worried about her spine. And she's losing function.
70, is that what you said?
72.
72,
female.
yeah. Mm-hmm. So, as you age, there's all kinds of things that our bones go through changes, and one of the places those changes happen is the column that your spinal cord is supposed to have room to move and be flexible in. When that bone change starts to push on the nerves, you can't have... Often there's pain, but sometimes it is just the foot drop, like she talks about, and the weakness that shows up. So it's not an easy diagnosis, but it makes me a little concerned.
That's right.
Also, you cannot forget that people who have pain or weakness that is provoked by activity, blood flow frequently needs to be assessed as well because it's a potential cause of problems.
So this person really needs to get in. He needs to go in and be seen, and if she's not getting answers from that physician and she's not comfortable, we need to catch another doctor because it sounds like something's happening big time bad.
Okay.
And it needs intervention.
All right. Shifting gears.
You agree with me?
Absolutely, absolutely.
I agree with you.
Consult.
Consult.
But I agree with you because, pain is a symptom and weakness is a symptom, but it's not a diagnosis. And so the treatment will be the most effective when the diagnosis is the most specific.
There's an indication for an MRI.
Yeah, absolutely.
I'm a Mr. Conservative MRIer, and I'd say,
I'd MRI that
there
one.
you go.
Okay. All right, a question from Sioux Falls, female, age 55. She gets a headache after eating. After eating wheat, excuse me. Is this common?
I've not heard it. I mean, my immediate thinking is you better test for celiac disease and get a tissue transglutaminase level.
1 in 8 is what they say.
But that's a slow thing. I mean, you wouldn't expect celiacs to get headaches after eating wheat, do they?
Well, if you have an inflammation response from it, you can see increased blood pressure. Yeah. So I would check for celiac disease. And again, you can stop eating wheat for a couple weeks and see if it goes away.
Okay.
And that's cheaper.
It's cheaper. But the tissue transglutaminase antibody blood test is $60 or $80, and then you've got a real good idea that is a celiac or not.
Now, if I go in for the blood test, am I supposed to keep the same diet that I've got?
Yeah, you shouldn't. I mean, actually, you shouldn't go on 3 months of gluten-free diet before you test because the test will go away.
The antibodies are going to hang around, though, so she could hold off for a day or two and the test would still be positive. But 3 months into it, it's not going to count.
Yeah. All right. 72-year-old lady from Flanders wants to know, she has sciatic pain in her legs. What's the best pain management while it's inflamed? So when that flares up...
I'm going to let Judith...
Well, And her primary problem is what, sciatica in both legs?
Yep, sciatic pain in legs.
And she is how old?
72.
72. You know, I tell you, I think one thing that people neglect to do that often really helps is if you have sciatica in both legs that's associated with walking, it can help to, first of all, be kind of focused on how you do your activities. So you allow yourself the opportunity to do the activity in a way that is measured. So instead of saying, I'm going to do all 20 of my errands this morning, you do 2 errands, and then you sit down and take a break. So activity modification, number 1. Number 2 is people often benefit tremendously from a stretching program, and particularly stretching of the hamstrings can be very beneficial.
Do you think this, I mean, what is your diagnosis? I mean, you've got an idea in your mind about what this lady has.
Well, you always worry about lumbosacral spinal stenosis, which is a doctor's way of saying, you know, there's arthritis that's pressing against multiple nerves, and typically that kind of sciatica is associated with walking because as we walk, there's less and less blood that goes to the nerves, and then the nerves experience pain, which is why stretching really, really helps.
But these people don't generally benefit with surgery.
So, well, it depends. You know, it depends. I would say that certainly some people benefit with surgery. And
if they're finding that they can't function, they walk so far and they can't go any further, and they can't get past that, and their exercise is tremendously compromising their life, maybe it's time to consider it then.
Right. I think that surgery is not. I think surgery needs to be thought about in terms of a wide palette of things that could be tried, including stretching exercises, medications, aquatic therapy, very beneficial for people with spinal stenosis, because you de-weight the spine.
Did you want to chime in on this?
Yeah, as a primary care, if somebody would come to me with that story, she's elderly, so I am actually worried about giving non-steroidals at too high of a dose, so you want to try and do something that could rescue her a little better. So instead of a non-steroidal anti-inflammatory, I might, if on the exam I can I can make the pain worse by pushing on the spot in their, sacral.
Fun! I don't want to come to you as a doctor.
If I can make it worse, yeah, you can you can give a shot of a steroid injection to see, can this help?
Yes.
And frequently, it's kind of a bartering system that I'll use to say, now this is the time where I want you to go into the physical therapist, or I want you to engage in that water program where you've said, oh, it hurts too bad, I can't do it. It hurts too bad, I can't do it. If this works, it'll take down that inflammation for 2 months or so, maybe 3 months if we're lucky. And during that time, if they can get those muscles stretched, if they can get on an exercise program, then it cannot come back, which is then everybody wins.
It brings up a critical point. You know, people who have pain that's, you're worse when you walk. Oh, I can't exercise. You know, that doesn't mean you can't use a seated bike. Mm-hmm. So there are other, there are ways to work around frequently.
Don't you love the fact that they both approach this very challenging problem with not saying, I'm sending you to the orthopedic surgeon, I'm going to get an MRI. I mean, the answer is help them deal with it. Do the conservative things. Do the physical therapy. Try, if you can, to get into activity. If you can get past that, over a 3-month period of time it isn't getting worse, then you're going to prevent a surgery, and that would be a very good thing.
All right. Well, we need to kind of wrap things up now. Dr. Bosworth, do you have 30 seconds or a minute's worth of wisdom, parting comments that you want to share with the audience?
I have patients ask me all the time, can I exercise late in the day? And I always tell them that the sleep studies were better for people who exercised right before bed than the people who didn't exercise at all. So even if the only time you're exercising is right before bed,
good to hear.
You still got better scores than when they didn't exercise at all.
Exercise is the best treatment for sleep.
Yep, absolutely.
Wow.
Dr. Peterson?
I think there's a phrase, it takes a village, and I would like people to think about that in terms of their approach to their own health and their own pain. And so instead of saying, oh, I have this pill and this is what's going to do it, I would like our patients to think about, this medication may help me. In addition to this stretching program, I will be doing this exercise so that I have overall better fitness and health with which to approach things. I will think carefully about my diet to make sure that I have adequate replenishment. And also, I will be focusing on my general overall health as opposed to focusing exclusively on illness, disease. I will think about my health.
Think about your
That's
health.
kind of a mindset shift.
Yes,
that we
and my take home is everybody walk a mile a day. You can do good vigorous exercises 3 days a week if you're going to, whatever it might be. Everyone would benefit a mile a day if you can. Thank you both very much for joining us.
Thank you so much for having us.
Okay, doctors, thanks so much. And now stay tuned. We'll take a quick break and we'll be back with the homespun perspective and then what's new in medical science.
Looking for reliable healthcare information online? You can start with the resources link at the On-Call website. From there, you can access a variety of accurate and dependable information sources, including the South Dakota State Department of Health and Medline Plus.
Some say my main job as a physician is to take away pain. But as bad as it can be, most of the time pain has a purpose. Pain can be both physical and emotional. Sometimes it teaches us to avoid harm. Sometimes it helps define a problem so it can be fixed. And sometimes it helps allow for healing. A 20-something-year-old light-complected woman came into the emergency room with a severe sunburn. She had forgotten the sunscreen before she climbed into that boat, and 3 hours later, after all that fun, she realized she was in trouble. Her bright red color and blisters indicated extensive first and second degree burns for which pain medicine, salve, and time were prescribed. I hope pain taught her not to do that again. A 50-something-year-old man came into my office this week with abdominal pain. It was dull, cramping, nauseating, and it drove the man to stand up from his chair and walk around the room ineffectively trying to find a comfortable position. The differential diagnosis included gallstones, pancreatitis, appendicitis, and intestinal obstruction. With further testing, we found a sick gallbladder, and surgery gave him relief. Pain helped define and resolve the problem. An 80-something-year-old gentleman came into the office with a thick callus on the side of his foot from bad-fitting shoes, and a blood blister under the callus had become an infected ulcer. It turned very painful, which helped him find a way to keep pressure off the sore so it could heal. It took 3 months, but pain helped allow for healing. A 70-something-year-old woman lost her husband to a month-long struggle with multi-system failure, starting with heart and then kidney and then brain. Then came the tough decision to stop life support and let go. I watched how deeply she suffered from this loss, from which there was no escape. But then how she allowed for healing by diving back into work and expanding her connection with family, spirit, and friends. The pain moved her to healing. Physical or emotional pain sometimes guides us away from harm, helps solve problems, and it allows for healing. A physician's job is not always to take that pain away. We'll be right back.
In our medical news tonight, throughout our show tonight, we've touched on the fact that pain is subjective and difficult to measure with precision. A new study by Brigham and Women's Hospital in Boston, Massachusetts, is investigating this and trying to utilize a new imaging technique to identify areas in the brain that respond to back pain. Scientists are using an MRI technique called arterial spin labeling to identify areas in the brain that are active when patients with low back pain have increased or more than usual pain. In a study with 16 healthy patients and 16 back pain patients, participants each had 3 imaging scans conducted. One was a baseline, one was done when temporary positioning would aggravate the back pain, for example, tilting the pelvis or raising a straightened leg, and the final image scan was done when heat was applied to the skin. The heat was applied in a way to match the level of pain experienced by the participants when they did their aggravated back pain scan. The intent here was to see if the brain responded responded differently to different kinds of pain. The results of the study showed that yes, in chronic back pain patients, a specific area of their brains responded only when they experienced a worsening of their back pain and not when they experienced heat-associated pain. The researchers involved in the study say that they hope their results may someday lead to therapies that can be tailored to individuals in order to provide better pain management. And that's all the time we have for tonight. Remember, On Call is rebroadcast on SDPB Digital Channel 2, Mondays at 11 a.m. Central and Wednesdays at 4 p.m. Central. Once more, I'd like to thank our guests, Dr. Annette Bosworth, Dr. Judith Peterson, and the On Call medical editor, Dr. Rick Holm. Thanks to our phone volunteers, and thanks to you for watching and calling in. Have a good evening.
Program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
To learn more about life and health, you can order your copy of The Picture of Health, a beautiful book containing insightful essays and evocative images by On-Call medical editor Dr. Rick Holm and Dr. Judith Peterson. This book, containing healthcare advice, stories of medical history, and meditations on healing, can now be yours for $17 at the South Dakota Ag Heritage Museum. Call 1-877-227-0015 to order. This offer is made by Ag Bio Communications at South Dakota State University.